daily. Thank you for listening to my musculoskeletal focused health assessment. So I had a patient present for a planned ketamine infusion to my medical surgical ward, presenting issues being chronic pain of a focal origin. So he sustained a traumatic neck injury as a paratrooper about 20 years ago, which involved a parachute accident and landing on his face basically and twisting his neck. So the associated pain as a result of that is predominantly left-sided, shoulder, lower back and migraine pain. Medications are Cymbalta for depression, oxycodone slow release 40 milligrams BD for pain, pregabalin or Lyrica twice a day for neuropathic pain, lactulose 20 ml BD to mitigate any possibility of constipation related to opioid use. And there's also breakthrough oxycodone, immediate release, PRN. No other medical or surgical history. So straight over to psychosocial history. He lives alone but has two teenage boys that live with him on weekends, and supportive grandma who attended with him for admission this day. DVA supported and funded as his accident occurred whilst in the army. Subsequent PTSD, anxiety and depression as a result of this traumatic incident. So ketamine at a glance, primarily it's a dissociative anesthetic agent. However, it also has anti-inflammatory, analgesic and antidepressant effects. And Zanos et al. There conducted a study indicating that a 5-day infusion actually has quite a good effect from patients suffering complex regional pain, as is the case with this gentleman. So on admission, pain assessment, cognition intact, orientated to time, place and person, verbally rating pain 8 out of 10, observation as listed there, concurrent with pre-existing pain and sympathetic nervous system activation. Reason for admission, just to clarify, is a ketamine infusion. So there's no recent MRI results or anything like that because this is a chronic issue. However, there was bloods done in the preceding days, and the CRP, which is indicative of inflammation, anything over 10 milligrams a litre is indicative of inflammation, and his results were 200 milligrams per litre. So the CRP is the C-reactive protein. It's an inflammatory marker. So the pain assessment tool, first one was the PQRST tool that I used. So the P being the pain or provocation. So it increased his pain if he was static in the same position for long periods or with sudden jerking movements. The Q, the quality of the pain. So there was a predominant ache or throb, and 40% of the time it was shooting and stabbing. Radiation, which would be pain in the neck, shoulders, that radiated mainly down the left arm with intermittent pins and needles or paresthesia into the forearm and hand, and the lower backache, and intermittent migraines. The symptoms associated, so nausea with the migraine, anorexia and sweating at times of increased pain. So the T for timing, he reports that pain is generally 7 out of 10 over the day, worsening over the last 20 years without an unknown etiology. He did mention, however, that there had been arthritic changes as per his GP report. Next, we've done the Kappa pain tool. So on that little picture there, we've got comfort, domain, change in pain, pain control, level of function, and any issues with sleeping as a result of pain. So his findings were on assessment that his comfort levels were tolerable with some discomfort. The changes in the pain, well, they didn't change, they were around the same. Pain control is inadequate, hence his presentation today, and his level of functioning, it stops him doing most things that he would enjoy, such as playing sport with his children, holding a job, and general things that we perhaps take for granted. Sleep has certainly been interrupted by this pain. He's awake with pain at night. He did mention that he was reluctant to take endone because he felt like he was already having too many medications that might have been affecting his level of drowsiness, and he wants to be present for his sons. So just the relevant anatomy and the mechanism of injury. So it was a traumatic fall with an emphasis on left lateral rotation and anterior posterior hyperflexion of the neck. So it's kind of like getting a whiplash. When he impacted the ground, it was on his face, mainly his left side, which forced the head and neck back. So this resulted in C1 and C5 nerve injury. So anatomical review, the skeletal system. So C1, or the atlas, is different from the rest of the vertebral bodies because it doesn't have a vertebral body. It's got a spinous process absence as well. There is an anterior and posterior arch, however, which articulates with the dens. So that's that peg anatomy on the picture there. C1 nerve functions, it protects critical CNS structures and it facilitates nodding, pivoting and turning. So you can imagine that those ranges of movement have been limited with. Next, C5 was the other injury site. So that nerve function forms part of the brachial plexus. And now that nerve system is responsible for shrugging, rotation, arm abduction, and a sense of feeling towards the tip of the shoulder. And the C5 dermatome supplies the skin over the shoulder, upper arm and forearm. So it's only congruent with the patient's report of the pins and needles down the left side of the arm that would indicate there has been C5 dermatome damage as well. So, musculoskeletal assessment. We inspected and I found that the neck had no swelling on that day. There was asymmetrical paraspinous muscles, however, around the base of the occiput. So that's consistent with spasm post-trauma. There's lordotic straightening or a slight loss of the natural C-curve of the spine, as this is a natural reaction to injury in and around this area. So the shoulders were asymmetrical in their height from front on. The left side was more hunched up, shall we say, and this is due to compensatory guarding and major pain. Palpation of the area, so you can't effectively palpate C1, or I couldn't that day. C2 to C3 muscles are asymmetrical and protruding with tenderness and limited range of movement at those sites, consistent with these osteoarthritic changes that the patient had reported to me. C4, C6 stiffness and the paraspinous muscle protrusion. Range of movement assessment findings. So as you can see there, the pain was at a minimum 6 out of 10 at all of those tests, and that occurred mainly about 10 to 20 degrees into the movements. So the tests measure or should normally be found to be around 40 degrees plus for those different types of movements. So this man was in quite a lot of pain. So the acute intervention were ketamine subcut infusion for 5 days, and that would be via a syringe driver, and that gets titrated up over the course of the week. Common risks with ketamine infusion are hallucinations, respiratory depression, subcut site irritation, nausea, vomiting, and feeling spacey or out of it. Interestingly though, ketamine has less of a respiratory depression effect than opioids. So we just monitored the infusion as per the policy where I work. Additionally, the Ramsay sedation score was used to monitor his level of consciousness. So the Ramsay sedation score has a score from 1 to 6, so 1 being completely awake and 6 being unable to respond to painful stimuli. So this was his second infusion 6 months ago, was the first one. Prior to commencement of the infusion, I went through the risks and side effects, expectations, and the verbal consent was of course obtained prior to the procedure plus written consent. The grandmother was present for the explanation of the procedure, and I notified him that the OxyContin would be weaned down over 3 days in line with an increase in ketamine infusion. So for monitoring, physical observations remained normal for this patient during my shift. There were no hallucinations. He did feel spacey, but did remain orientated. He was sleeping more soundly also. So between 3 to 6 hours, his pain had reduced post commencement of the infusion from 8 at the start down to 3, and then 1 at 6 hours post commencement. And the Ramsay sedation score, pleasingly, was 3 at a worst, which correlates with being mildly sedated but able to commands. Patient outcomes. So the pain relief goals were achieved this shift, and he was successfully weaning OxyContin at day 3. Range of movement was reassessed. He did have musculoskeletal pain after this period, but his pins and needles in his left forearm and hand had gone, which was consistent with that C5 dermatome impinging on that sensation down that arm, and the pain was reduced to 2 out of 10 for the remainder of the week, which was a good thing. So the prognosis and priorities for this gentleman would be, we would aim to reduce opioid use due to its CNS depressant effects, respiratory depressant effects, and GI depressant effects. Recommended a physiotherapy referral, although he had been there before. With this reduced pain, he may be able to achieve some more exercise throughout this reduced pain period. Mental health referral was important for this man because there was a lot of burden on his mind about his inability to be an effective father. We maintain that Lyrica for neuropathic pain, as pregabalin has increased benefits for patients with long-standing peripheral neuropathic pain, such as in his hands, arm, fingertips. And Panadol Osteo was maintained for arthritic changes in the cervical joints and lower back pain. So the priorities continued would be that there was an emphasis on optimising this young dad's quality of life and level of function, and to enable him to re-engage with some achievable activity levels and to enjoy being a father again. And that is all. These are my references. Thank you for listening.